Good evening, everybody. Today I'm going to present a class on FFA. Uh, I'm Dr. Aiswarya N S, and this class is moderated by Dr. Preethi P. Coming to the history of FFA, Von Baer is a person who first synthesized the molecule of fluorescein. MacLean first used this in humans, and H.R. Novotny and D.L. Elvis are the people who developed the first FFA. FFA involves the photographic surveillance of the passage of the fluorescent dye through retinal and choroidal circulation following intravenous injections. So it helps us in studying the retinal and choroidal pathologies. Before coming to the principles of FFA, we need to know some terminologies. The first one is luminescence. It is the luminescence is a property of emission of light from any other source other than the heat source. That is, it can be a chemical reaction or an electrical reaction. Fluorescence is the luminescence that is maintained only by continuous excitation, and phosphorescence is the luminescence where emission continues even after the excitation has been stopped. Coming to the sodium fluorescein molecule, which is the dye used in FFA, it is an orange-red crystalline hydrocarbon with molecular weight of 376 Dalton. It is water-soluble in nature and alkaline. 80% of it is protein-bound, mainly to albumin, and the rest 20% is responsible, which is unbound, is responsible for the fluorescence. It absorbs blue light of wavelength about 465 to 490 nanometers and emits a yellow-green light of 530 nanometers. It diffuses rapidly to other body fluids due to its low molecular weight and high water solubility. It is excreted in urine over 24 to 36 hours. Coming to the anatomy, the retina has a dual blood supply, the central retinal artery and the choroidal circulation supplied by the short posterior ciliary arteries. The central retinal artery supplies the inner half of retina. The inner blood retinal barrier is formed by the tight junctions of the endothelial cells. It does not allow bound or unbound fluorescein molecules to pass through it. So if there is any disruption in this inner blood retinal barrier, there is leakage of these bound and unbound fluorescein molecules into the extravascular space. The RP tight junctions form the outer blood retinal barrier, and the unbound particles can pass through the fenestrated walls of choriocapillaries into the extravascular space, crossing the brush membrane, but it is prevented by the RPE cell tight junctions. So if there is any break in the RPE tight junctions like RPE atrophy and all, it causes the passage of these molecules into the extravascular space. So this is a diagram showing the outer blood retinal barrier. We can see the tight junctions between the RP cell called zona occludens and the fenestrated choriocapillaries. The fenestrated choriocapillaries allows the unbound molecules to pass through it, but the tight junctions prevent its entry further. The inner blood retinal barrier is formed by the tight junctions of the endothelial cells. It doesn't allow, if it is intact, it doesn't allow the bound and unbound molecules to pass through it. If it is disrupted, they pass into the choroidal, they pass into the extravascular. Coming to the principle of FFA, so sodium fluorescein dye is the dye which is used in this, and it absorbs light of wavelength 465 to 495 nanometer, which comes in the blue spectrum, and emits light of 525 to 530 nanometers, which is in the green wavelength. So there is there is an excitation filter and a barrier filter. This excitation filter allows only the blue light to pass through it, which is it is placed in front of the flash of the fundus camera, and dye is injected IV. Of this, as I already told, that 20% of the unbound fluorescent molecule is responsible for the fluorescence. So the blue light from the fundus camera strikes the fluorescent molecules, and it emits a green light. Some of the blue light can also be reflected back, which is prevented by the barrier filter, which doesn't allow the blue light to pass through it. So this is the diagram showing it. The white light is coming from the light source, and it is striking the excitation filter, which allows only blue light to pass through it. The blue light reaches the retina, fluorescent molecules in the circulation, and from these fluorescent molecules emits the yellow green light, which passes through the barrier filter and then reaches the charge coupled device or the film. The reflected blue lights are not allowed to pass through the barrier filter. Coming to the indications of FFA, it includes the retinal vascular disorders like CRAO, CRVO, and all, macular diseases, ARMD, uh, choroidal pathologies, and the retinal vascular malformations and tumors. Coming to the instrumentation, Zeiss FF450 plus camera with magnification levels of 20, 30, and 55 degrees is used. And the wide field is by Spectralis by Heidelberg, which shows a simultaneous FFA and ICG. Coming to the procedure, adequate pharmacological mydriasis is needed. The procedure should be explained and consent should be taken. The emergency resuscitation tray should be ready, and patient should be seated comfortably in front of the fundus camera, and color photographs are taken. A standard IV cannula is inserted, and fluorescein, usually 3 ml of 20% solution, is drawn up to the syringe and injected over 5 to 10 seconds, not rupturing the cannulated vein. And oral fluorescein angiography is also there, where a dose of 30 mg per kg is used with it is mixed in orange juice and can be ingested. And pictures should be taken at 20 to 60 minutes following the injection. In FFA, the images are taken at 1 to 2 seconds intervals, initially to capture the critical early transit phases, beginning 5 to 10 seconds after injection, and tapering the frequency through subsequent phases. When monocular pathology is there, control pictures of the opposite eye are taken after the initial transit phase has been photographed in the index eye. Coming to the adverse reactions, due to the dilatation drops, the side effects can be there. Other than that, the IV procedure-related side effects include the most common ones are the discoloration of skin and urine, nausea and vomiting, which is the most common side effect, and local reaction due to the extravasation of the dye. Thrombophlebitis and necrosis, tissue necrosis can occur. The less common ones are syncope, asthmatic symptoms, and hives. Least common are MI prophylaxis, anaphylaxis, pulmonary edema, death, which are very rare. For reducing the nausea and vomiting, we can inject the dye slower, like we can inject the dye with like 5 to 10 seconds in 5 to 10 seconds, which reduces the chance of nausea and vomiting. And we can also give prophylactically the antiemetics. And to prevent the anaphylaxis, hydrocortisone injection is also given along with the dye. Coming to the contraindication, the absolute contraindication include allergy to the fluorescein molecule. The relative contraindications include pregnancy, especially in the first trimester. Especially in the first trimester, the molecule does not cross the placenta, but it is best avoided. Moderate to severe asthma, renal failure, in which reduced dose can also be given, and significant cardiac diseases and other blood dyscrasias are also contraindication, is also a relative contraindication for FFA. Coming to the dosage, here we give 3 ml of 20% sodium fluorescein, or 5 ml of 10% sodium fluorescein, and 10 ml of 5% fluorescein is also can be used. According to the weight, the volume is calculated. Coming to the artifact, one of the artifacts is blooming effect, which is due to the increased intensity of the camera flash. It can cause a marked hyperfluorescence, which can be suspected as leakage in the leakage, which can be suspected as leakage. There can also be like blurred images, which is due to hazy media. Coming to the phases of fluorescein angiogram, there are like 6 phases: choroidal phase, arterial phase, early arteriovenous, late arteriovenous, recirculation phase, and the late phase. Coming to the choroidal phase, it happens 10 to 12 seconds after dye injection in young patients, and 12 to 15 seconds after injection in older patients. The early choroidal fluorescence is faint, patchy, and irregular. It is also called as a choroidal flush. If the ciliary retinal artery is present at this phase, it gets filled during the choroidal phase. Arterial phase, it happens 1 to 3 seconds after the choroidal fluorescence. You can see the filling of the arteries. The central retinal artery is getting filled. Next is the early arteriovenous phase. This includes a complete filling of the arteries, arterioles, and the capillaries. Uh, laminar flow of the veins is also seen in this phase. This laminar flow of the vein is due to the blood flows faster in the center than in the periphery. So the fluorescent molecules will get accumulated in the peripheries, causing the hyperfluorescent with a hypofluorescent uh, part in the middle. This is the late arteriovenous phase. The veins have completely been filled. It happens 20 to 25 seconds after the injection of the dye. Recirculation phase happens after 30 seconds of dye injection, and the fluorescence of the vessel reduces as the more amount of dye is going to recirculation. Next is the late phase, where it occurs after 10 minutes of injection. There is staining of the brush membrane, sclera, choroid, resulting in a diffuse background choroidal fluorescence. The disc is seen hyperfluorescent in this phase. Coming to foveal avascular zone, fovea appears like hypofluorescent because of three main reasons. It is best seen in the venous phase or the 20 to 25 seconds after the injection. The fovea appears dark due to the absence of blood vessels in this area, and the blockage of the background choroidal fluorescence by the increased pigment melanin in the RPE cells at the fovea, and the blockage of the background choroidal fluorescence due to high density of xanthophyll in the macular area. Uh, this is the timeline. Injection of dye is at 0 second. Choroidal phase starts at 10 second. Arterial phase starts 1 to 3 seconds after the choroidal phase. Early arteriovenous phase 14 to 15 second. Late arteriovenous 18 to 20 second. Recirculation after 30 second, and late phase after 5 minutes. So the arm choroid, the time taken by the dye to reach the choroid from the site of injection is called the arm choroid time, and it is normally 10 to 15 seconds, and we call it abnormal when the delay is more than 30 seconds. Arterial phase, normal, it is 1 to 3 seconds, and delay, it is called delayed if it is occurring more than 5 seconds. The arteriovenous transit time is the time of appearance of the dye in the retinal arteries to the veins. The time difference between the appearance of the dye in the arteries and the veins is called the arteriovenous transit time. It is normally 8 to 12 seconds, and the delay is when it is more than 15 seconds. Coming to abnormal fluorescence, uh, abnormal fluorescence can be hypofluorescence or hyperfluorescence. Hypofluorescence, when the fluorescence is lesser than what is required at that, what is normal, is known as hypofluorescence. It can be blocked fluorescence or vascular filling defect. Hyperfluorescence, when the fluorescence is more than normal, it appears like whiter. It can be caused due to window defects, leakage, pooling, and staining. So this is an image showing blocked retinal and choroidal fluorescence. You can see in this fundus photo, we can see the heme which is obstructing the view, retinal and choroidal view. As the vessels are not seen, we can say that the heme is located in the pre-retinal space. It is causing a blocked fluorescence. Fluorescence. This is an image showing the blocked choroidal fluorescence. Here you can see uh, uh, the retinal vessels are seen in front of the uh, retinal vessels are seen uh, in front of the block fluorescence. So we can say that the heme is present behind the retina. So it is a subretinal heme which is obstructing, causing the blocked choroidal fluorescence. This is an image of the blocked disc fluorescence due to an disc melanoma causing blocked disc fluorescence. Coming to the filling defects, filling defects occur when there is an obstruction to the vascular flow or capillary dropout. It appears as patchy hypofluorescent islands bordered by the vascular margins without any overshadowing of the vascular margins. Here you can see that there is filling of the dye at this level, and after that the dye is not getting filled into the artery, suggesting an occlusion at this level. So this hypofluorescence is known as vascular filling defect. Coming to hyperfluorescence, it can be leakage, pooling, staining, and window defect. Leakage is early hyperfluorescence that increases both in size and intensity. In late phase, it means that the fluid is going into an open space. Uh, this is an example of leakage. Here you can see in the early arteriovenous phase, uh, uh, we can see hyperfluorescent areas of leakage, which hyperfluorescent areas which increases in intensity and size in the late arteriovenous phase, suggesting leakage. Next is pooling. It is an early hyperfluorescence which increases in intensity but not in size, indicating that the fluid is getting accumulated in a closed space. This is an fundus image of CSR where there is fluid is accumulated in the fovea. In this, we can see this is an early arteriovenous phase of FFA showing uh, hyperfluorescence in the hyperfluorescence, and this hyperfluorescence increases in the late phase. The intensity of the hyperfluorescence increases, but the size remains the same, indicating it is a pooling of the dye that occurs in this phase. Next is staining, which is a late hyperfluorescence. It is caused due to tissue absorption. So it's a late hyperfluorescence, but that is not increasing in size. In this FFA image, we can see a hyperfluorescent scar, hyperfluorescent area in the near the macula, which increases in intensity in the late phase, suggesting of scarring, staining. And then there is window defect, which is also known as the transmitted fluorescence. It is a early hyperfluorescence that retains in size but reduces in intensity in the late phase. Here we can see hyperfluorescent area in the above the fovea, which in the this is an early arteriovenous phase showing the hyperfluorescent area in the above the fovea, which decreases in intensity in the late phase, uh, uh, suggesting of a window defect is usually seen in RP atrophy. So the background choroidal fluorescence is being seen in this phase. Coming to pre-injection fluorescence, it involves there is autofluorescence and pseudofluorescence. Autofluorescence is the inherent property of a lesion to cause fluorescence spontaneously, even in the absence of the dye. It is seen in optic nerve drusen and astrocytic hematoma. Pseudofluorescent, as Sir already told, it is a non-fluorescent blue light which is reflected prior to dye injection. Like it is due to the mismatching between the barrier and the exciter filters. Coming to the clinical conditions, first is central serous chorioretinopathy. We can see different types of leakage patterns in this condition, known as ink blot pattern, smokestack pattern, and inverse smokestack pattern. In chronic CSR, we can also see the pigment epithelial tracts, which are actually transmission defects in the form of tract, which is starting from the posterior pole and expanding inferiorly to form a teardrop or a dumbbell or hourglass appearance. So, ink blot appearance, it usually starts as a point leak at the RPE and spreads symmetrically in all directions in the subretinal phase. This is an ink block leak where you can see in the initially here in the early arterial phase, if we look closely, we can see some hyperfluorescence in this area, which increases in intensity and size in the early arteriovenous phase, and we can see the ink blot leak in the late arteriovenous phases, causing leakage. I call it leakage because the intensity and the size of the leak has increased in this image. The other one is smokestack pattern. It starts as a point leak and ascends to reach the highest point of detachment and then expands laterally in an umbrella or mushroom lake pattern. Uh, this is the appearance in smokestack leak, where you can see it is starting as a point leak and then it is ascending above. And then in the later images, we can see that it is forming a mushroom or an umbrella pattern. So this is known as the smokestack leak. If it happens if it goes downward and forms the similar pattern, it is known as inverse smokestack appearance. And this is the RPE tract. This is fundus imaging showing mottled hyperfluorescence, which is extending from the disc margin to the inferiorly along the uh, macular downwards. So this is the RPE tract, which is seen in chronic CSRs. Coming to diabetic retinopathy, the indications of FFA in diabetic retinopathy include it is a sensitive method for the assessment of fluid leakage in diabetic macular edema. It is used for the assessment of the foveal avascular zone, its size and regularity. It showed the stage of diabetic retinopathy and the assessment of the number and location of microaneurysms, which are all important in the treatment. Detection of intraretinal microvascular abnormalities or IRMA, and early neovascularization, which can be missed on clinical examination, and differentiate from other causes of CME like pseudophakic CME and drug-induced CME. The FFA changes in diabetic retinopathy include microaneurysms, vascular leakage, capillary dropout area, IRMAs, neovascularization, and the assessment of the foveal avascular zone to know if macular ischemia is present or not. So microaneurysms, they appear as hyperfluorescent dots which leak in the later phases. Capillary closure, it appears as hypofluorescence due to non-filling bordered by due to non-filling, and it will be bordered by dilated capillaries and microaneurysms. IRMA, they appear as irregular segmental dilatation of the retinal capillary bed, which remain with the confines of retina and do not leak fluorescein except minimally at their growing tips. Uh, so this is a differentiating feature between IRMA and neovascularization. IRMA, they won't leak in the later phases, while neovascularization, they leak. It freely leaks the dye. And superficial and deep retinal hemorrhages can cause blocked choroidal fluorescence. So this is a picture of microaneurysm where you can see as dot hyperfluorescence, which increases in intensity and size in the later phases. This is a picture showing uh, uh, IRMA, where you can see a network, hyperfluorescent network of capillaries, just superior to the foveal region. So this is the IRMA, and we can see a lot of microaneurysms and other leaks. This is a picture of neovascularization of disc and neurovascularization elsewhere, where we can see hyperfluorescent areas of hyperfluorescence with uh, fuzzy margins, and suggestive of neovascularization of the disc. And this is an area of hyperfluorescence with hyperfluorescence suggesting a neovascularization of elsewhere. And this is a blocked choroidal and retinal fluorescence due to a pre-retinal heme. Coming to diabetic maculopathy, it can be focal, diffuse, mixed, or ischemic. It is called focal when the microaneurysms are causing the leakage for more than like 2/3 of the leakage is caused by microaneurysm. It is known as focal. And if it is diffuse, if the leakage is caused by other than microaneurysm, like the microaneurysm is contributing only less than 2/3, it is known as diffuse maculopathy. And ischemic when there are capillary non-perfusion areas. Mixed can be a combination of any of the above. So this is a FFA image showing focal leak. As we already told, we can see that most of the leakage is contributed by the microaneurysms. This is an image showing diffuse leak where we are not able to see the microaneurysm causing leakage. Uh, this in this image we can see the it is a FFA image in late phase, showing a petalloid appearance at the macula, suggestive of CME. Multiple hemorrhages. This is the FFA image showing there is a profuse disc leak is there, with the foveal avascular zone is enlarged, with enlarged, and it is irregular. The normal counter is not seen, suggesting of macular ischemia. So it is an ischemic maculopathy.
So this hyperfluorescence is bordered by the blood vessels. So you see the limitation.
Yes.
Beyond the that blood vessel, here it is hyper, here it is hypo. There's ischemia here within this vessel area, okay? Whereas here it is hyperfluorescent, okay? This is again bordered. So this is a capillary non-perfusion.
Coming to choroidal neovascular membrane, it can be classic CNVM or occult CNVM. The classic CNVM, it appears as a bright, well demarcated area of hyperfluorescence, which show a lacy network of vessels in early phase with leakage in the later phases. Occult CNVM can be like fibrovascular PED and late leakage of undetermined source. The fibrovascular PED shows speckled hyperfluorescence plus persistence of staining or leakage of the fluorescent dye in the late phase. It can be well demarcated or poorly demarcated. The late leakage of undetermined source show the leakage of dye at the level of RPE in the late phases of the angiogram. So this is an example of a classic CNVM in which we can see in the early phase, in the early arteriovenous phase, we can see a area of hyperfluorescence, a lacy network of hyperfluorescence, which is surrounded by a blocked retinal, a blocked choroidal fluorescence, suggestive of subretinal heme. In the later phases, we can see the increase in the uh, intensity of the uh, intensity, suggesting of classic CNVM. This is a picture showing stippled hyperfluorescence uh, near to the fovea, which also increases in intensity, suggesting of an occult CNVM. Coming to central retinal artery occlusion, uh, 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 it's in acute stage. It shows considerable marking of the choroidal fluorescence due to swelling of the overlying retina. The arterial phase is extremely delayed, and progress, but the slow progress of the dye is seen in the arteriole. There is a marked delay in the AV transit time, and the optic disc shows staining during the late phase. So this is a fundus photo of uh, fundus photo showing a hyperemic disc with tortuous vessels and uh, area of widening, and multiple hemorrhages can also be seen in this photo. So this is an early arterial phase showing there is like delayed filling of the arteries, and these are the later images showing torches. This is an early arteriovenous. The first one is an early arteriovenous image showing uh, torches, vessels, and multiple areas of blocked choroidal and retinal fluorescence.
I was telling the first image, left one. The first image.
Okay. First image is we can see the laminar flow in the vessels, suggestive
I'm
of
asking about that image. Yeah. What else you see?
we can see it is an early arteriovenous image showing dilated tortuous veins with blocked choroidal and uh, retinal fluorescence can also be seen.
What is that dark line coming from the disc onto the macula? Is it an artifact or something else?
It is
There
due
is
to
one dark line in the papillomacular bundle going from the disc towards the macula, curving up across the fovea. What is that?
it can be an artifact.
What?
It can be an artifact.
It can be an artery or it is an artery.
Uh, it is. Ma'am, artery, which is a delayed filling in the arteries, is seen in that.
Which artery is that? You have an earlier phase of this angiogram?
Yes, this one.
You see that same vessel, no? In this angiogram?
Yes,
What is that vessel? Look at the color photograph. What is their area of distribution of the whitening?
supranasal, ma'am.
Supernasal? That's the distribution of the chorioretinal artery, no?
Ciliary.
Hmm. So that vessel is not filling even in the AV phase. Don't you
Yes.
think that's a problem?
Yes, ma'am.
Yeah, when you bring these cases, make sure that you describe them properly. Okay?
Okay.
Yeah. Okay, proceed.
So this can be a case of combined CRAO plus CRVO.
It is not CRAO. You saw the retinal arteries filling up. Go to the earlier phase. What time was it? The time you are not put, but the arteries are filling quite early, right?
Yes, but this area of whitening.
Yeah, so that's why the ciliary artery is supplying that area. So it's a ciliary
Ciliary
artery
artery
occlusion.
occlusion.
It's a central retinal occlusion with a ciliary artery occlusion.
Okay.
Okay, so that's why the ciliary artery is not filling up. It's filling up in the much later phases after the retinal veins are filled actually. Okay,
Yes.
in the middle image it is filled, but in the first image it's not filled, right?
Yes.
But in the first image the veins have already filled, no? But the ciliary artery is not yet filled.
Yes.
The ciliary artery is supposed to fill in the choroidal phase, not even in the retinal phase, because it comes directly from the behind actually, not from the retinal artery, right?
Yes.
It's supposed to fill in the choroidal phase,
Choroidal
but so delayed. Okay, this retinal whitening can be explained by ciliary artery occlusion.
occlusion.
Okay,
Coming to central retinal vein occlusion, it can be non-ischemic CRVO or ischemic CRVO. It is called non-ischemic CRVO when there is a delay in the venous filling, uh, engorged disc capillaries, superficial retinal heme can be there, vessel wall staining can be there in the late phases, cystoid macular edema can be present, and when the capillary non-perfusion area is less than 10 disc diameter. Ischemic CRVO has all the features of non-ischemic CRVO, but the capillary non-perfusion area diameter will be more than 10 disc diameter. And the ischemia may extend to the macular region also, and there is marked delay in the filling of the veins. So this is an FFA image showing the first one is an early arterial phase image showing marked delay in the filling of the veins and areas of point dot hyperfluorescence, which in the later phases we can see the tortuous veins and more leakages, and in the late phases we can see the tortuosity and the leakages has increased. Coming to branched retinal vein occlusion, it can be non-ischemic or ischemic. When it is less than 5 dis, when the capillary non-perfusion area is less than 5 dis diameter, it is known as non-ischemic. And
It's
when
not branched retinal vein, ma. All retinal veins are branched. It is branched retinal vein. Okay.
trans, the macular edema, which can be perfused, non-perfused, or mixed. In perfuse, there is an intact capillary network with late leak. In non-perfuse, capillary dropout areas can be seen, and mixed, both can be present. We can see the tributary vein which is not getting filled, suggestive of a non-ischemic TRVO. We can see the capillary non-perfusion areas. Coming to retinal artery macroaneurysm, the macroaneurysm, it fills in the early arterial phase of the angiogram. It can be occasionally hypofluorescent in early films due to the slow filling, and in the late phase, it can vary from minimal staining of the vessel wall to marked leakage. The dilation of the surrounding capillaries, adjacent areas of capillary non-perfusion, and microaneurysms may be seen in some cases. If a retinal hemorrhage is there, the macroaneurysm may not be visible on the FFA. So this is the early uh, um, uh, early arterial phase of the fundus fluorescent angiogram, showing some vascular hyperfluorescent areas.
What phase?
Early arterial phase.
Do you see filling of veins in that? Whether the veins are filled or not? The first image, whether veins are filled or not?
No. Yes, yes.
Yes or no?
Yes, no.
So it's what phase?
Arteriovenous, late arteriovenous phase. Uh, in this uh, in this image, we can see the increase in the filling of the hyperfluorescent area, uh, s- uh, hyperfluorescent area, and this in this uh, late phase late phase image, we can see the leakage leakage of the we can see a hyperfluorescent outpouching and the surrounding leakage, suggestive of a retinal artery macroaneurysm. Coming to polypoidal choroidal vasculopathy, it is better visualized on an ICG. In FFA, it can be sometimes the polyps can be seen as a stippled hyperfluorescent, which increases in intensity and becomes fuzzy in the later films. This is an Heidelberg spectralis image showing some stippled hyperfluorescent uh, areas in the various phases of the FFA, suggestive of a polypoidal, suggestive of an IPCV. In the ICG image, you can see the polypoid phases more clearly.
Which one is FFA? Which one is ICG?
This is FFA and this is ICGs.
Look at the disc. How is it on FFA? How is it on ICG? At least in the late phase.
Hyperfluorescent.
Yeah. So disc will always be hypo and
ICG.
ICG. Okay.
Coming to Behçet syndrome, it shows diffuse retinal vascular leakage and occlusion of the retinal vessels. During acute inflammation, retinal vascular leakage is prominent, especially in the radial peripapillary area. The affected retinal and optic nerve vessels leak fluorescent profusely during early transit phases, and their walls stain in the late transit phase. It may reveal macular ischemia and CME also. So this is the FFA image. Uh, this is an early arteriovenous. First one is an early arteriovenous image showing multiple innumerable leaks, which is increasing in intensity and size, causing a fern-like appearance in the uh, late phase of the FFA. Coming to VKH, it also shows numerable tiny leaks at the level of RPE in the early phase of the angiogram. The late phase show characteristic pooling in areas of exudative RD. Late staining of the optic nerve head can also be seen. In resolved stages, where transmission window defects can be noted in areas of RP atrophy. Areas of hyperpigmentation cause blocked fluorescence. So this is an FFA image of right eye and the left eye, showing some disc disc hyperfluorescence is seen, along with numerable leaks, which in the later stages is increasing in intensity. Coming to the advantages of wide field angiography, the imaging beyond the 50 degree of field is known as wide field photography, and it includes ultra wide field and wide field. This is a table showing the region and anatomical location and the field of view of the various FFAs. In wide field FFA, the mid periphery is seen, which is extending from the vascular arcades to the posterior edge of the vortex vein ampulla. It extends 60 to 100 degree. In ultra wide field, the far periphery can also be seen, which includes the anterior edge of the vortex vein ampulla and beyond to the pars plana, which covers an area of 110 to 220 degrees. So this is the optos. It shows has an area of view of like 200 degrees. And Heidelberg spectralis, if it is contact, it has an area of view of 105 degrees and 55 degree in non-contact. The only limitation is like limited view of the superior and inferior periphery. The advantages of the wide field FFA includes it can view the peripheral pathologies, the peripheral vascular leaks and all in diabetic retinopathy, which can be missed. It can be all the peripheries, findings in the peripheries in all the other diseases can be seen, like vein occlusions, pediatric retinal diseases, peripheral tumors, and uveitis, etc. This is a fundus fluorescein image of a wide field FFA showing the peripheral region. This is a case of familial exudative vitreoretinopathy, where we can see an avascular area in the periphery with numerous neovascularization elsewhere, which is can be seen leaking in the later phases. As I already told, the limitations is the resolution is slightly lesser. Right, resolution is lesser, and there is image distortion in the periphery as the 3D image is converted to a 2D image. Lash artifacts can be there, and there is limited view of the superior and inferior retina. Thank you.